Welcome to the City and Hackney Neighbourhood Team Frailty Training Resource. This resource will help increase your awareness of the social impacts of living with frailty, shares the experiences of residents living with or at risk of frailty, and it will also signpost you to additional resources to help improve your practice. The learning activities are optional and consist of 3 simple steps. Each of the 3 activities involves reading the provided materials, completing a multiple choice test, and receiving a certificate upon completion.
I'm always worried about something. I don't like going out because I'm worried I'm going to fall. I don't like people behind me.
Loneliness is a very, very bad thing. You never know until you get into that situation. Sometimes I like to be on my own, yeah? But another time, it is boring to be by yourself all the time.
They need to say, okay, got people to come, bring their medication, make sure they get their medication on time, or make sure if they have to walk out, they have somebody to go with them or whatnot. Because on the street is not that easy like before, maybe like before. And social care, they need, the old people them need a lot of social care.
Frailty is vulnerability. We can measure frailty in a couple of different ways. One is more focused on physiological factors. Another way that it can be measured is by what we call accumulated deficits, and that's really by adding up lots of things that can go wrong at later stages of life.
So that's where it's difficult, because frailty is a diagnosis for somebody who is older, over 65. So I guess it would be that we would see somebody as more vulnerable. So it's about that vulnerability. So again, a physical vulnerability.
What is frailty? Frailty is a condition that makes individuals weaker and more vulnerable to health problems, resulting in a decline in physical strength and energy. This decline can lead to increased reliance on family and caregivers for daily activities, which may cause feelings of loss of independence and frustration. As individuals experience frailty, they might find it harder to participate in social activities, leading to isolation and potential mental health issues like anxiety or depression. Additionally, needing more frequent visits to healthcare services can create stress and worry about their health and finances, affecting their overall sense of well-being.
Frailty becomes a problem for people as they get older, because there are a lot of health issues around getting older, unfortunately, and they can be anything from risk of falls, limited mobility, sort of bladder, bowel issues, dementia, memory issues in general. As people get older, it can cause them to be at a higher risk of becoming frail. But we do know there are sort of proactive steps you can take to help reduce that risk.
5, 6, 7.
The benefits for me, because before I started to sniff, I was feeling all kind of pains. And they said to me it was Marcia, actually, that told me about the chair exercise. So I didn't know. All I thought they did boxing. Yeah, I didn't realise they did exercise. So I came, and then since I've been coming, all my joints have feel loose there, so I can do more.
The big problem with falling is that we fall. We have our first fall, we're not injured, but we're shaken. So what is the natural reaction to that? Oh, I was so lucky. I didn't get hurt. You know, my friend Muriel, she fell and broke her hip. Or I mustn't do that because obviously I could fall any time. So suddenly, oh, I need something from the shop, but you know, my daughter's coming this weekend. I'll wait and get her to do it. Or I'm not going to get up and make dinner. I'll get my daughter to bring food in for me, or my son, or whatever. So people start doing less. The trouble with that is we start here, we start doing less, we lose muscle. If we're not using our muscles, they will just go. So what happens is you start getting weaker. If you're weaker, you fall. So then you get another fall. Oh my goodness, I'm really falling now. I'm going to do even less. All you're doing is making things worse and worse and worse. And then one day. And that works with families as well, because families will come in, no, mum, sit down, I'll do it. Or no, don't you go out, it's cold outside, I'll do the shopping for you. And with the best will in the world, I understand why they're doing it, but it is the worst thing that they can do. And I think for people in the community working with older adults, what I would say is they need to encourage people to remain active, not to be afraid of that activity, because it's the activity that will stop them falling. So don't do things for them, do things with them.
If I want to go to the shop, it's a hard thing for me. Lately, I don't know why. I don't know. I think because you get older, your body get weaker and you're frightened you might fall over, things like that. I don't know. But and sometimes I'll have to call my nephew because he's not working on, because he's the same age as me, but he looks much younger. So he'll come and stay with me and I can send him to the shop, but he don't know what he's buying.
How do we communicate frailty with younger people? It's difficult because it's a term that we use with ageing individuals. So I guess I probably don't use frailty with my patients because it might put some people off. I think sometimes vulnerability or just identifying their difficulties, and sometimes people haven't actually identified them themselves, so sometimes just acknowledging them and showing appreciation for the difficulties that people are actually experiencing can open the person up to being able to take on help. Because I think often, especially people who may not have been open to the idea that they are suffering with lots of difficulties, or they may be aware, but actually they may not have fully understood what is causing them to struggle with their day-to-day life, and we can help them do that. I think I'd always say, just be honest with your GP. Tell them what's going on in your mind. We have certain questions that we should be using. You're much more comfortable speaking to the receptionist. Just let them know, and then the GP or the clinician should be able to ask you the additional questions to get to the bottom of it.
Welcome to Chapter 1, Ageing Well in City and Hackney. As professionals and volunteers, we play a very important role in supporting older residents at a very vulnerable stage in their life. But while ageing is inevitable, There's some very simple things that you can do to help older residents reduce the risk of greater frailty. What you'll hear in this chapter is stories of older people themselves, along with the professionals that support them. City in Hackney is a diverse place to live, work, study, and to enjoy leisure.
In 2020, the London Borough of Hackney created its very own Ageing Well strategy. We created this strategy because it was a promise that we as politicians had been elected on. Our older citizens wanted us to have a very clear strategy about how we would help them age well. And so working with our older people, we created the Ageing Well strategy. And I think it's very important that we remember that was co-produced. We got 5 coordinators who were all older people themselves, so all over the age of 55, and they went out and spoke to hundreds, thousands in fact, of other older people, and also some younger people, especially professionals who worked with older people, and said, what are the important things that will help us as individuals in Hackney age well?
Unfortunately, I've got no friends in the area.
Okay.
Let's say as people that I used to go out with. Unfortunately, they've all died.
This wasn't the area that when I was living, I was living in Tottenham. This is Stoke Newington, yeah. And then don't forget, I went on for 18 years before I come back. So all those friends, I know I got families, but they're far out in Edmonton or Enfield and things like that. I don't see them very often, especially young people. No.
The majority of people who come to us are older, and that is usually because they've had an incident or maybe a crisis even that has caused them to have a limited social network, so they become more isolated and lonely, and that can cause mental and physical health issues as well.
Frailty in City and Hackney is a really important aspect of patient care that we want to look at, because we know that in City and Hackney residents may become frailer younger in certain areas, in certain boroughs. And so certainly in my neighbourhood in Hackney Marshes, we are looking to identify residents who are likely to become frail at a younger age, but also are potentially being affected by frailty. So although frailty in itself in the kind of medical model looks at older people, so that they're less likely to be able to deal with normal day-to-day activities when they're aging. But actually we know that residents in City and Hackney are more likely to be affected by deprivation and kind of where they've come from, what they've experienced, their life experiences, other health concerns that may affect their what we would, I guess, term frailty at a younger age. So we want to be able to pick up those people and ensure that they can live healthier, longer, happier lives.
So there are a lot of success stories about growing older in Hackney. Hackney is a really vibrant place. There are lots of stuff going on culturally. There are loads of restaurants. So we've got lots of libraries. We've got a really kind of active voluntary sector, albeit operating in difficult conditions. There's a lot of activities and community activities for people to access compared to many other places in the UK. But being a kind of a minority in terms of age, and with social trends like gentrification and the cost of living crisis, it's really important that we do what we can to support older people to keep going out, to keep accessing cultural activities or keep doing the things that they want to do. And I think part of that is challenging ageism, because there's a sense across the UK, UK is a very ageist society, unfortunately, and we all internalise ageism. So we think that dementia, frailty, loneliness, these are all inevitable parts of ageing, and they're not.
The bus driver, they may see you come, and instead of, when you go into the bus, they know that you have a walking stick and they know you're disabled. They only say, hold on for 2 minutes and let you sit down. They drive off because they try straight on your face. One day, a bus conductor was in the bus, one who took tickets and so was in the bus, and I just go in the bus and I was going up. As soon as I go in the bus driver, no, wait until you let me sit down. He just drive off one time, and me just drop straight from my face. And the lady stand up and say, and stopped the driver and said, do you know you could lose your license? Is an elderly person come into the bus, and you couldn't even wait for they sit down, you drive off. Or you say, sorry. Sorry. But sorry, can't fix the damage. Well, I love to say, like, when we go into church, I have something to come and pick me up, because sometimes I could collapse on my feet sometimes. And not that easy, because enough times I go into the bus, my knees then give out on me. And me have to very hold on strong.
We can help people with their GP referrals, help with flexibility, mobility, strengthening, you know, and just feeling good about yourself as well. So I think if those kind of communications were put in place, those things were more implemented, I think it'll be better for the community as well as going to the gym. But, it could probably give them a start. But you know what, I feel a bit confident now. Let me try the gym. And have a bit of a challenge.
Feel strong enough.
It would be great if places like this, because I love seeing people getting better. I love seeing people. I love seeing the improvement. And I have to make sure it's done. It's a part of my life. It's what I love to do. So it's just nice to see these ladies come in. They've come in. They've started off a certain way. Then within a few weeks' time, you start seeing them stretching a little bit more, pushing a bit more. So it means a lot to me. Yeah, it does.
So I think Hackney is unique and really special when it comes to trying to prevent frailty and maintain independence. We have lots of contracts that we are part of as GPs to keep people healthier, and that's the proactive care for the neighbourhoods, which is looking at patients who maybe aren't accessing services now but may become frail in the future, and trying to keep them independent and put things into place in order to reduce their need for accessing services. We have practice-based proactive care for primary care, so in general practice, which is patients who may need to see their GP fairly regularly, who need a bit more support. And then we have the frail home visiting, so patients who are housebound, who will be visited 4 times a year in order to ensure that we are proactively managing their conditions and ensuring that we pick up on anything before it becomes too much of an issue. But we're really lucky in City and Hackney also in that the services that are provided by the Homerton, so the Integrated Independence Team, the Adult Community Rehab Team, they are all there in order to keep people independent, keep them out of hospital, because we know that if people go into hospital, they become weaker quicker, and we need to keep them in their own home, keep them physically active in their own home, so they'll see a physio, an occupational therapist, somebody who can keep them mobile, and if they're not mobile, keep them in their home and provide carers, and because we know people often want to stay in their own home and are often happier in their own home.
We have multidisciplinary meetings where there are kind of a specific issue which might benefit from kind of different lenses. So having a GP plus a social prescriber plus your health and wellbeing practitioner plus your care coordinator to sort of say what's going on for this person, and can we all add a little bit to kind of supporting them with their development. I guess the other part is, it's on a footprint. It's not something which is across all of City and Hackney. Each of them are embedded within a local footprint, so they're working across primary care networks and on a neighbourhood. And so that means that you get to learn, there are these 3 lunch clubs nearby, or I have this walking route that goes through here. I know which libraries are in my area, which is the gym. I know that we have these really vocal champions in the resident forum. I can put people in touch with those bits. And so working on that footprint means that the relationships that the team can develop are sort of much more local and therefore more integrated around where people live.
The Community Befriending Service started at VCH in 2015, so it's nearly 8 years now that we've been going. Initially, the Befriending Service was for lonely and isolation, people who were lonely and isolated in the borough, and it was usually older people. But during the pandemic, we expanded at a great rate because we were getting referrals for people who were basically on lockdown or sheltering. So we expanded from sort of 75 matches to sort of over 150 matches, and that was in a few weeks during the pandemic. But the core aim of the community befrienders are to sort of target those people who are feeling isolated and lonely in the borough, but also who want to get more physically and mentally active and reconnect with the community. It's just really health conditions as well, and that could be if they're maybe living in poverty, so that could have an effect on if they may be more at risk of becoming frail, because if you have good sort of healthcare and you have good accommodation, things like that as well, and good diet as well, that could all affect your risk of it. It would probably lessen your risk of becoming frailty, but also as well in that it's community support as well. So that might be community engagement, so people don't feel isolated and lonely, and that can help increase their mental health positivity. Or it could be kind of like, just being able to have access to community resources. So if somebody has got limited mobility and can't access things out in the community that will help them, or can't get access to the information about it, that again might increase their risk of becoming frail as well. I mean, there's lots of resources around their GP, so their social prescriber would definitely be somebody that I would say to go and talk to, because they are, as well as signposters, they can look at advocacy as well, and they can actually have lists of the resources in the borough. And they're based at GP surgeries as well. And then you can also there are resources on Hackney Council's website and things like that as well. So if they haven't got family, friends, or a befriender to come in and talk to them, there are those resources. I would say start off with your GP, because there's usually somebody there who can help.
We see a real resilience and joy of the people kind of coming through, despite having lots going on in their lives. People, I think, are receptive to kind of having the conversation and wanting to kind of take control.
The thing that we really want to bear in mind all the time is it's always about doing something with people, not to people. That classic phrase of nothing about me without me.
Learning activity. City and Hackney works closely with key partners to support its older residents, and its strategy has 7 priorities. Hackney as an employer, social and civic inclusion and respect, health and well-being, public spaces and transport, housing, safeguarding safety and security, and employment and skills. Time to read the supporting learning documents and discuss them with your colleagues. And remember to complete the multiple choice exercise. You'll find all of these by scanning your QR code or clicking on the link in the description. Welcome to Chapter 2, Making Every Contact Count. What is Make Every Contact Count?
Making every contact count is a very simple idea. It's that all of us in our day-to-day lives, whether we're working, volunteering, or we're simply living in an area, we're talking to people all the time about lots of different things. Some of those conversations are opportunities to make every contact count. When we're talking to people, we try to be person-centred, to take a moment to hear about how they experience life, how they're thinking about their health and well-being, and to be responsive to that, get in their shoes for a moment and see things from their perspective. Because if we can do that, we'll have better conversations, we'll make more progress with people, even in quite a short period of time.
I'm Joel Reynolds. I'm one of the managers in an adult community rehab team. In that first conversation is very much that personalised needs assessment, using what matters to you. What does good look like to you? What does a good day look like to you? Are there any kind of current challenges with things? So kind of fairly open kind of questions, but in a semi-structured way, so that the care coordinator can gather the information from the person about what's going on for them. And it might be, I'm not in touch with my daughter and that's upsetting me, or my landlord is not responding to my calls about my thing, or I'm really short of money this month, or my health is kind of whatever. It's really wide ranging. And through that, the care coordinator is then able to sort of make a bit of an action plan with the person to say, this stuff is all going on. What actually would help to kind of like address some of these things? And they bring their knowledge of what's happening in the local area, so of different social groups or of different kind of like eligibility for benefits, or actually I've noticed on your GP record you haven't booked in for your annual check on your diabetes. So they would combine sort of health and social kind of information with the stuff that the individual is finding important to make a personalised care and support plan.
I probably wouldn't actually go out because I don't like, let's say that I won't go to groups because I don't like being part of a group.
Okay.
I'm a loner. And I don't like any group activities. I'll do anything not to have to go. You lose a lot by being like that, but I've always been like that all my life, so I'm not going to change in my 80s, am I? I really need somebody to go with me. It's got to be somebody I know. From time to time, we go to the theatre in Finsbury Park. We got a bit fed up because we've seen so many bums, naked bums. When you've seen one, you've seen enough.
Well, when I came here, we used to go to a club, the Salvation Army, down in Lower Clapton, and that was fun, really, really good fun. But after the COVID started, that everything went down flat. And after that, I just didn't. There was no other club that I liked. I like it down there because there's so much things going on that every day I used to go except Saturday and Sunday. And I had some good friends down there as well, you know. So that's why, but after the COVID and everybody disappeared and they stopped doing it.
That's all we do, we just chat.
What difference has that made?
A big difference, because I don't have family. I'm in the UK on my own. So, you know, have somebody to talk to, not on the phone, but somebody that you can relate to and that you can moan to about things.
Yeah.
Despite having lots going on in their lives, people, you know, I think are receptive to kind of having the conversation and wanting to kind of take control. So that is wonderful. And even when you've had a number of kind of challenges, being able to kind of do that is great. I guess as a community, we see lots of really good things. You know, there's food banks, there's walking groups, there's you know, sort of churches doing kind of singing. That's great for lung health. You know, there's healthy eating groups and kind of, you know, talking about like free ways of learning and how to kind of manage both your budget but also eat healthily to kind of manage kind of condition type stuff. There's really kind of resource community services. So despite delays everywhere, in comparison to other parts, it's able to kind of say, oh, actually, did you know you can get this access to kind of your to the gym, or did you know that this is happening in the local library centre? So I think there's lots of different bits, and it's such a diverse group that there's bits which really kind of support and can be tailored to kind of individual interests.
There's good evidence now that's been evaluated by the National Institute for Health and Care Excellence that shows that people do go away, think about what we've discussed and act on what we've discussed. There's a pyramid of intensity in terms of people's needs and the level of support they require for it. So making every contact count really sits at the bottom of that. It's something that lots of people can get involved in. That's quite light touch, it can be quick if required, and just gets people thinking.
Learning activity. Every contact that we make with an older resident in their homes or out in the community can be optimised. And the supporting materials will help you to maximise every contact that you make. From very brief, extended, right through to high intensity interventions. You'll find those supporting materials by scanning your QR code or clicking on the link in the description. Chapter 3. Health Inequalities. City and Hackney is a richly diverse borough with people of all backgrounds, faiths, cultures and life experiences. What do we mean by health inequalities? Health inequalities are difference in health and well-being between different groups of people. These differences can be caused by factors like where people live, their income, education, ethnicity, race, or access to healthcare. People from poorer backgrounds or disadvantaged communities often face worse health outcomes compared to others. Reducing health inequalities means making sure everyone has a fair chance to live a healthy life regardless of their circumstances.
So Hackney actually has a really young population, right? So only about 8% of the population in Hackney are older people, and they are actually the second most kind of income deprived group of older people in England. I think the first is Tower Hamlets. So it's a tricky situation, and there are a lot of challenges, a lot of health inequalities, but also there are a lot of success stories about growing older in Hackney. And we've got programs like Hackney Circle. The aim of that program is to enable greater access to the arts and culture. There's also like an arts and culture network that's to do with health, specifically the benefits of creative activities and accessing culture for health. So there's loads and loads of stuff going on that we can draw on to really have a vision of Hackney and make Hackney a place that is a really exciting place to age well, and where all those opportunities to engage in cultural diversity, to overcome isolation and to be creative can really be realised despite the challenges.
Racism produces impacts on the opportunities a person will have in life, opportunities even to get the treatment they need. So I look at health inequalities like anything. There's a lack of opportunities. It produces the result of lack of opportunities an individual have. Why I'm making this distinction is that there is a tendency to brush over inequalities by saying, look at your 4 fingers. Everybody cannot be the same. There's a difference. And difference is, and there is some genetic aspect to it. So some fault lies with you and your parents and all that. But no, the major impact for me, the inequality, is the deprivation of opportunities.
Inequalities that we see are very strongly related to economic inequality. So in East London, as individuals and as whole areas, people have experienced lower income, poorer outcomes when it comes to employment status as well. And those types of factors are very strongly related to the health outcomes that people experience. So it's a combination of things to do with people's personal living circumstances, such as their income and employment status, but also how that affects whole areas in terms of access to employment, access to services, and access to resources that are needed for healthy living.
I live here about 20 odd years now. Yeah. Since 97.
97.
I come to England. Mm-hmm. And when I come to England, it seems like me want to go back home right away. Because the feelings when we get home, I don't get it here. And the relaxation you get home, you don't get it here. Like your brain is all over the place. You study so much. How to get this way, how to make a living. And it might be look cheap, but it's difficult. Especially for when you're going up in age. And especially with have to go to the doctors. Ain't nobody will drop you to the doctor. You have to get there how you could. No ambulance and nothing will come to you. And the thing of it, when I come here, the first place to start to work is Hamilton Hospital. And then from Hamilton Hospital to a school, and from a school to West End. I used to work in the city. I want to make myself a man. I want to get married. I want to settle down and get my children and whatnot. And I started work, but work was difficult because I used to get something like £150 a week, and as soon as I get that day, it just gone to rent, electric. I couldn't buy food.
I came in this year, 1999.
1999?
Yes, that's it, 1999.
Okay.
That's when my husband died. That's why I'm here, because I was meant to be here. I was living in Jamaica. And then but I normally come on a holiday, yeah? Because I was over here first, but I took sick. And I have to go back home to recuperate because, girl, if I didn't go back home, I don't think I would be alive. I had like a breakdown. So, but I normally come back to see my daughter that was at school up here. And then my husband took sick and I didn't. And he died, so I didn't bother because she had a special needs son. So I was helping her with her special needs son. And that's why I'm stuck here.
I don't have any family.
Okay.
So I've got a vague cousin in Switzerland.
But that's fine.
Because I was adopted, you see, so I've got no blood family at all.
Okay.
That I'm aware of.
The messages that have been out there and how people communicate with one another, it's always been like we try something and the places that we go to, we don't feel too comfortable, or it just seems, it's like, it could be like a culture thing as well, just the way how we move, the way how we do things. It's like even when I've done chair exercises, the music that they used and taught us was all from the English, from the 1940s and things. And I'm thinking, my group's more Caribbean. How does this relate to them? So play the music that they loved, encourage, put that atmosphere, that kind of, just like with all the places I've gone to, it's always been English music or British or stuff like that. So I'll play the reggae music, look while I was from the Caribbean.
Music has a lot to do with
It's a part of our culture. It makes them feel good while they're listening. I've got them engaged now. I've got their tunes on in the background, but also they're giving me the attention that I need as well.
And what we've been saying, there's not enough like clubs or classes for this age group.
There isn't.
So this is why I feel so good to be around this age group.
I think we need to think of ways to keep our residents happy and healthy for whatever their needs are. So, for instance, we have to, if people are fasting, we have to think about how we change their medications. But also, if somebody is frail, we need to give them advice and guidance on what they should do with their medications, if it is safe for them to fast and not drink water. Is it okay for them to fast and not have food but have water? And I think you mentioned before about discussing, if somebody is praying, going up and down from the floor very often, they're probably going to be a bit more agile than somebody who hasn't been doing that all of their life. And having that muscle memory is so important because if somebody falls over, they're going to know how to get up if they've been getting up from their hands and knees from praying regularly, compared to somebody who hasn't maybe been on the floor for a long time.
Many cultures either, as you say, go to the ground to pray, or just within, not necessarily their faith, but may be seated on the floor at the dinner table, not sitting on a chair. One of the big problems we have with falling is, let's say someone falls and is not injured, bumps or bruises, bit shaken up, but they can't get back up. And a lot of physios and fall prevention clinics work a lot in getting people onto the floor and up again, and that's something that people need to work on, because one, it takes strength to get up and down. So if you are very frail, you simply don't have the capacity to pick your own body up off the floor. But two, often we're stiffer, we're not as flexible as we used to be. It can be a skill that you may need to learn, and people are taught to do that. But yes, I was discussing this at home the other night, watching a television program based in India, and people were squatted working, including older people. Didn't bother them in the slightest. They could get up and down. Having said that, The people actually in the TV program we were watching with were clearly also frail, the older people, because they were, the particular group I was watching were poor. They were working in a factory. And so they didn't have a lot of muscle either. So it is not the only thing, but yes, I think being able to get up and down safely, using those muscles regularly is a good thing. But it doesn't stop you from being frail. A third of people over the age of 65 fall every year, and that goes up to 40% over the age of 80. And that's the classic figure that's bandied around all the time. And the first thing I asked was, well, is that the same for everyone? And looking around, no one had ever asked that question, or no one knew. So I did a systematic review and looked at data from all over the world on different ethnic groups, and found that yes, different ethnic groups report falls differently. Now we have to add the caveat here that we only know if someone's fallen over if they tell us. There's no measure for falls, particularly because unless you're injured, yes, we do have measures for injurious falls of hospitalizations and so on, but most falls, thankfully, don't give you a major injury. So we always have to have a slight question in our mind, are people telling us about their falls? And often no, because as we said earlier, they might not define falls the same way. They may not have hurt themselves, so that was just a tumble, that's not a fall. So if we tell people a very clear definition and look at falls, they still might not tell us because they have concerns. Oh, my family will think I can't cope. They're going to put me in a home. I will think I can't cope. You know, there's a lot of reasons people might not tell you. So if we just keep that thought in the back of our minds and just look at the falls they do report, we find big differences. And we don't actually know for sure why those differences happen. We can make some inferences and some guesswork. So the people that fall the least worldwide are typically in the Far East. So Japan, China, Indonesia, Malaysia. And a lot of the thoughts about that may be that the attitude to aging is very different. That older people are respected, are revered, that it's okay to use a cane or a walking stick to show that you're old. In fact, there's many cases people see it in the same way. If we see someone with a white stick and a guide dog, we give them a bit of room on the street. In Asia, if you're using a cane, people will give you room. They'll offer chairs to you. They'll look after you. They might support you. You know, even strangers will sort of help you. So there may be less opportunities to fall and more acceptance of assistance, whether it be technology, a walking stick, or a person. So there's a lot of reasons like that. The people that fall over the most in terms of worldwide studies are white people. And again, that's possibly because culturally we're fed regularly that aging is bad. Aging means weak, aging means mentally feeble, that you are not employable, that you're fairly worthless. You know, whether it be ladies and their eye creams to stop wrinkles or attitudes to older people in the workplace. I mean, we're all very afraid of being older. Older people in European ethnicity type categories will often, I'm not old, I can do this, I can do that. So we tend to get a lot more falls outdoors. We get a lot more falls from people trying to do DIY or climbing trees to chop off branches and things. So things that perhaps are not wise decisions, but they don't see it as a problem because they're not old. When I had a look in specifically here in London, I got data from a major GP chain across London looking at falls. It was anonymised data, just gave me the number of falls in a year, the person's age, their ethnicity and their gender, and came up with a lot of surprising factors. The groups that I thought I might be studying, I wasn't. The African population here and around East London don't fall terribly much at all, which was really good. The two groups that I found fell the most were the Bangladeshi and the Caribbean populations. And from numbers, there were more older adults, Caribbean older adults, because we have both the Windrush generation and now their children were just coming into the over 65 category. So very interesting, because I have these sort of double groups of older adults within that particular ethnic group. So yeah, I was interviewing, talking to people about their attitudes to getting older, how they feel about being physically active, how they feel about falls, lots of things like that. And really, really interesting results. And then the idea is I'm going to be trying to design an intervention specifically tailored towards the likes, dislikes, preferences, barriers, facilitators for particularly Caribbean older adults.
We are really lucky to have a very diverse team of care coordinators and kind of clinical leads, and they bring a lot of kind of lived experience and kind of rich different backgrounds and kind of heritage. So although we wouldn't match an individual to a specific kind of person, we wouldn't sort of go, all right, you're Jewish, you must see a Jewish person. The team is able to kind of share that experience. And so we have, we have men and women or across kind of an age range from sort of late 20s, I think. I don't know their exact ages, so I won't say that. But we have a really rich and kind of diverse group. It was a concerted effort to do inclusive recruitment. So we went out flyering around community centres, gyms. We went to making sure that people were able to kind of engage with the service despite, not maybe thinking that they had health experience. And that means that we do have people from the global majority. We've got sort of UK nationals. We've got different genders. We've got people who've got experience of long-term health conditions themselves. And I think they're a tight team. They share their experience. They're able to talk about experiences both working in social care previously, but also their own personal experience as Black women or a Black man or an older white man or a younger white woman. So as a diverse, inclusive group, they're able to kind of share some things, and I think that helps them to be sensitive to the differences and the different experiences that people have accessing the service. Thinking about like the age range really is, we know both deprivation can cause frailty to kind of happen earlier, but also certain conditions. So people with a mild learning difficulty or learning disabilities are likely to become frail earlier and have that kind of like susceptibility for kind of illness earlier. And other marginalised groups. So what we try to do really is thinking about kind of traveller and kind of migrant communities. So there's been research to look at the barriers for that, and that talks about trust, talks about kind of engagement. So by trying to offer appointments in different spaces and also a more intensive kind of outreach, go into the spaces where people hang out, go into the community clubs, sort of working in churches and out in kind of the community, is to try and engage people which may be disenfranchised from kind of healthcare or our health system.
I've only done 4 months here. I mentioned it to my mum, and now my mum's starting to come. Yeah, so he comes along just to communicate. Yeah, talk with the others, play games. It just gets around the house.
And how did you sell it to your mum?
I said to my mum, Mum, you know the Petra around the corner? Yes. I said, do you know all the ladies that you do exercise with? So she goes to an exercise class down the road. They come along and they socialise after exercising here. And she said, one day you can take me down there. So I met her and I brought her along. And since then, even if I don't come, she's not missing it.
She's so good for it.
Great, yeah. Really enjoys it. In fact, it's right on our doorstep. Yeah. Nothing about it.
Yeah.
We do need to think about the real impact of people's life experiences, of different experiences of discrimination, of structural and institutional issues that make it easier for some people to age well, make it harder for some people to age well.
Learning activity, health inequalities. Hackney is a richly diverse borough with people of all backgrounds, cultures, faith and life experiences. This diagram outlines the social determinants of health. And these are further outlined in the link that you'll see in the supporting materials to the Marmot Review. So take a close look at that and consider how this may well be impacting on the residents that you support. You'll find those supporting materials by scanning your QR code or clicking on the link in the description.